In 1846, a young doctor, Ignaz Semmelweis, began working in a maternity ward in the General Hospital in Vienna. Semmelweis wanted to understand why so many young women were dying from childbed fever. In the 1800s, childbed fever was a serious hospital-acquired infection, which was often fatal. Semmelweis studied 2 different wards in this hospital. One was run by male doctors, and the other by all female midwives. He counted the number of deaths, he crunched the numbers, and in the end he discovered that the women who gave birth in the doctor's clinic died at a rate nearly 5 times higher than the women who gave birth at the midwife's clinic. Now, it took him a while to figure out what was going on here, what the difference between the 2 actually was. In the end, he hit on the answer, nearly a year after he started his process. He realized that the doctors were also doing autopsies, while the midwives were not. He hypothesized that particles from the cadavers were being transmitted to these young women who would fall sick and who would then die. And so he ordered all of the medical staff in the hospital to wash their hands in a chlorine-based solution. Thus, he gave rise to hospital-based infection control. When he implemented this policy, we see that the rate of deaths from childbed fever decreased rather dramatically, from 1 in 5 to nearly 1 in 100. Sadly, many of the doctors were not so excited about this new hand-washing policy, and he was actually fired less than a year later. And we see actually that the cases of childbed fever started to rise once again. What Ignaz lacked that we have now is data, and the ability to quickly and efficiently analyze that data to understand things like childbed fever. Hospital-acquired infection is still a major problem today. 5% of inpatients will contract a hospital-acquired infection at some point during their stay. The costs of this are quite large. A single patient might rack up a hospital bill of about $20,000. But the health system's cost can be astronomical, somewhere in the range of $35 to $45 billion each year. That's a lot of money. But it's the loss to human life that we're really concerned about. 720,000 people will get some form of a hospital-acquired infection in a given year, and about 75,000 of those will die. These deaths are preventable. Clostridium difficile is a diarrheal infectious disease that hospitals are particularly concerned about right now. It causes somewhere in the order of 100,000 cases in the hospital setting each year. C. diff, as its name implies, is a very difficult disease to get rid of. It's highly resistant to antibiotics. It's very easy to transmit from person to person in the hospital setting. And it actually has a fairly high reoccurrence rate, meaning that if you get it, you're often likely to get it again, which is quite unfortunate. Unlike Dr. Semmelweis, we now have the data and the tools to investigate hospital-acquired infections like C. diff. In fact, since 2008, about 9% of hospitals had an electronic health record system. This has grown rather exponentially over the years, such that in 2015, about 84% of hospitals now have some form of electronic health record system. The Wexner Medical Centers have always been way ahead of the curve. They had a fully operational and implemented electronic health record system back in 2008, and actually in 2012 received an award for how wonderful their system was. What electronic health record systems are supposed to do is provide high-quality integrated patient care. This is because with the electronic health records, all of the clinicians that are involved in a patient's care can actually share and integrate and use information, providing whole patient care. This is a great move forward. But what it does is create massive amounts of data, big data. In fact, healthcare is literally drowning in data right now, largely because of electronic health record systems. We have information on patient demographics and diagnoses, medications, all of their progress notes and medical histories, as well as lab test results and radiology images. This is a lot of information, and it's really difficult to process, largely because it's actually often stored in totally different databases with totally dubious linkages between them. But in the last 10 years, we've developed a lot of techniques and methodologies for harnessing the power of large data sets, such that we can identify problems and solve those problems before they become a crisis. This is what's called the big data revolution. My research uses mapping and spatial analysis to harness the power of data in electronic health record systems with the goal of reducing hospital-acquired infections. The methods that I use aren't actually all that new. They've been around in geographic sciences for decades. But what is new is their application to the health system and to hospital-acquired infections. I take little bits of unorganized and unstructured data, and I turn it into information by processing and mapping it so that it becomes information that's usable. I then can pass that information to the health system, to CEOs, to clinicians, to nurses, to patient safety experts, so that they can use that information to address problems like hospital-acquired infection. As a health geographer, I actually see the world as a series of spatial linkages, links between people and places that lead to some sort of a health outcome. So what that means is that when I think about hospital-acquired infection, I don't just think about a patient and their risk factors. I also think about the rooms that that patient has been in and out of during their hospital stay, and the staff that they interact with and move around with. This gives me a slightly unique perspective on the hospital system. I see it as a big city where people are constantly moving around and interacting, instead of just a building. So when most people think about the Ross Hart Hospital, they might think of this. It's a beautiful facility. When I think about the Ross Hart Hospital, I see it a little bit differently. I see it a little bit more like this. This is just a 3D rendering of all of the floors and the rooms in the Ross Hart Hospital that I have put into my mapping program. When we have all of the information structured in this way, we can actually start to drill down. We can look at one floor or one ward in that hospital. Or perhaps we're interested in one specific room. Because the thing is that rooms, places, they actually have risk factors too, just like patients. This is a typical acuity care room in the Ross Hart Hospital. Again, it's a beautiful facility. The field of geographic information science gives us the tools and the methods to measure things about that room, such that we can collect data and organize it and process it. My research team is actually currently conducting a survey of hospital rooms in the Wexner. And what we're doing is collecting information like this: the room size, whether or not there's furniture in the room, and if there is furniture, what material is it made out of? Is there a sink in that room for the clinicians to actually wash their hands in? And if there is a sink, does it have a faucet aeration unit on it? All of these have been identified by our infectious disease doctors as risk factors for C. diff infection. Once we have this information, we can integrate it in the mapping program with all of that information on patients from the electronic health record system. And when we do that, we create more sophisticated and complex models of C. diff infection in our hospital environment. What that allows us to do is target interventional programs, such as the new UV light sanitation technology that the hospital is using. We can tell people which room, after which patient, they should go use that technology in. This is a great step forward. Add on top of all of this an understanding of how people move around the hospital setting. Every single time somebody interacts with a patient and logs it in the electronic health record system, they create a table that says who they visited and when they visited them. We can actually link this with the geographic information of where that patient was in the hospital at that given time. And this allows us the ability to create something called a mobility network. Mobility networks actually come out of transportation sciences and urban planning. And when we overlay something like that on our map, it might look like this. We can integrate this information with our patient-level information from the EHR and all of our hospital room information from the survey that we did. And we get a much better understanding of how the disease progresses through the hospital system, the transmission dynamics, and the spatiality of it in the end. The goal of all of this is to integrate all of this information into some sort of a system that we can harness it and use it to make decisions. What I typically do is use techniques that have been developed in community health and urban settings to monitor and to catch epidemics of diseases. We can use something like this. This is actually a ward in the hospital, and you can see that I've colored it according to the number of C. diff cases that were there. I can ask questions like, is there truly a cluster of disease? And if there is, what are the patient and room characteristics that drive that cluster? Because there's a point of intervention. Or perhaps we're a little bit more interested in how disease progresses over time, so that we can understand how the disease moves through hospitals. We can use spatiotemporal analysis to monitor epidemics as they move through the hospital setting, and hopefully stop them before they progress further. The goal of all of this, of course, is to integrate all of this information and to try to stop outbreaks in the hospital environment before they even occur. Most hospitals, no fault here, often catch epidemics a little bit at the top of the epidemic curve, when the majority of the cases have occurred, because that's when you really start to notice that something's going wrong. And in fact, some hospitals even catch it a little bit after that, on the downside of that epidemic curve. The methods and the techniques that I use are geared towards catching that epidemic much earlier on in the epidemic curve before the majority of cases have even occurred. Think how many lives we could save. The goal overall, of course, is to perhaps stop future outbreaks from even occurring. When I think back to Ignaz Semmelweis, as he struggled to understand the dynamics of childbed fever in that hospital in Vienna, I think about how much easier his job might have been if he'd had all of the information and data and techniques that we have today. He tried to stop childbed fever in one ward in one hospital in Vienna. If we can harness the power of the data stored in our electronic health record systems, we have the potential of creating a disease-free hospital of the future. Thank you.